Hey guys, welcome to part 4. We're in this podcast. We're going to continue talking about step 3 concepts. Last time I think we left off on congenital immunodeficiencies. Just to wrap that up, some of the congenital immunodeficiencies that are less high yield and they're pretty uncommon are the complement deficiencies. Now there's only 3 that are kind of tested, so we'll go through them pretty briefly. First, we have the C1 esterase inhibitor deficiency. That one is going to cause an increase in bradykinin angioedema. Remember, angioedema has 2 main sources. It's either going to be histamine or bradykinin mediated. Now, in the bradykinin mediated side, we have this C1 esterase inhibitor deficiency, and we also have ACE inhibitors. So it's important to get a history on these people to make sure that it's not an ACE inhibitor cause that's creating their edema versus this congenital C1 esterase. This is also autosomal dominant, I believe. So a positive family history is also going to be shown in these kinds of diseases. And if you need a recap on the complement cascade, I have videos on those going more in depth into the biochemistry. Next, I think we can talk about terminal complement deficiency, which is the MAC complex. This is C5 to C9. In these deficiencies, people are going to get recurrent sepsis because their body can't handle infections well at all. You need complement to kind of poke holes in the bacterial membranes in order for them to die. So the testable concept here is you have a person with recurrent sepsis and recurrent pyogenic infections, and then you do something called a CH50 screening assay. So in this case, I believe you have some sheep red blood cells on a dish, and then you mix this with the serum from the person in question, and you activate their complement cascade. And you see how long it takes for half of those sheep red blood cells to lyse. And if it takes a longer time than the standard, you can have this MAC complement deficiency. So that's the CH50 test. And the last one I think that's tested is C3 deficiency. Now C3 is particularly important because it's an opsonizer, which means it's the key connection point between complement, antibody, and the immune cells that are coming to attack. So C3 is going to attach to the bacterial cell, causing the initiation of an immune response with antibody and later on down the line the immune cells. So these people are going to have childhood infections, and usually this is associated with something like a type 3 hypersensitivity reaction. So if we remember, type 3 is an antibody antigen complex, but people usually forget the third part of type 3, which is complement. So if you have overactivation of this type 3 hypersensitivity, you're going to consume a lot of your complement, and then that's going to cause a C3 deficiency. On that topic, actually, let's just go through very briefly the different hypersensitivities so we can get a grasp on what type 1, 2, 3, and 4 are, because I know for me it's been a while, and maybe for some of you it has as well. Let's go through type 1, 2, 3, and 4, okay? So type 1 hypersensitivity, what are some key things to know? It's IgE mediated, so you have to have prior sensitization. You form a bunch of IgE against your antigen, then that IgE cross-links and causes degranulation of mast cells. So when mast cells degranulate, they release histamine, and histamine has a few key functions. One, it's going to cause smooth muscles to contract, so you're going to get bronchospasm and abdominal cramping. Abdominal cramping is a key one because people don't think about it much. And then peripheral vasodilation is also going to be there, so hypovolemia, hypotension. This is essentially your anaphylactic shock, hypersensitivity, okay? And the third one is pruritus. It's going to cause itching on top of that edema, so hives is very common in type 1 hypersensitivity. So remember, for type 1, it's fast, it's allergy, it's atopy. You have these pruritic hives, which are well circumscribed plaques, and you'll commonly get it with people who are allergic to things like food, drugs, toxins, etc. So remember that, because towards the end we have type 4, which is sometimes a little bit tricky to differentiate from type 1, but we'll differentiate them because both of them have skin presentations. but type 4 is T cell mediated. So moving on to actually before we move on, I think we should talk about a little bit about the treatment. So we have H1 receptor blockers, things like sertrazine are good to use in this kind of situation because the histamine pathway is overactive. You can have EpiPens. Remember, EpiPens are great for anaphylaxis. They essentially do kind of the opposite of what histamine is trying to do. Instead of constricting the bronchioles, they dilate them, and they constrict the blood vessels instead of dilating them. Helps you to maintain your fluid balance. Also, make sure you remove the offending agent, obviously. If a common one will be a child that's wearing some kind of new clothes that they're allergic to, or new jewelry, and then you see that they're constantly going in and out of anaphylaxis. You're giving them epi. Make sure you remove any of the offending agents, essentially make them naked if you have to, so that they're not still in potential contact with whatever they initially touched. Okay, and many of these people are prescribed EpiPens to go home with just in case there are potential problems later on. All right, so type 2. Type 2 is your hypersensitivity reaction that's cytotoxic. So what happens here is you have an antibody. Instead of IgE, it's either IgM or IgG, and that's going to attack your surface antigen. So this surface antigen is usually associated with autoimmune disorders. So you have things like lupus, you have things like Graves' disease, SLE, Goodpastures, myasthenia gravis is another one. So in these cases, you're going to have basically an FC receptor mediated immune cell activation, where your antigen antibody complex, where your antigen is on the surface of a cell, your antibody attacks it, and then the FC receptor kind of throws in the whole inflammation pathway down the line. Things like hemolytic disease are in this category, where you have preformed antibodies to those surface antigens on red blood cells, depending on ABO incompatibility. So type 2 is cytotoxic, which means it requires the NK cells, the macrophages, to come in after the antibody attacks, and it's antigen antibody mediated. So in things like Goodpastures, you'll see the linear deposition of antibodies if you do a fluorescence stain, and so you'll have these common linear depositions if you do a fluorescence stain on tissues. Their autoimmune is very common here, and IgG, IgM. All right, type 3. Type 3, and don't worry, we'll do a quick summary at the end just in case you guys missed some of these points. So type 3 is essentially complex mediated. So it's referred to really another name for type 3 is immune complex reactivity. And you have here an antibody, which is usually IgG, and it forms an immune complex with an antigen. And this immune complex is not stagnant like we saw with type 2, where it's usually in a tissue like the kidney or the lung. This immune complex is going to travel because it's small, and it travels and deposits in places. It's going to deposit in either blood vessels, it's going to deposit in the kidneys, where it causes inflammation, vasculitis, and essentially destruction of that tissue over time. Okay, so these are systemic diseases. They form antigen-antibody complexes, and those complexes are inflammatory because they then activate neutrophils, lysosomal enzymes, complement cascades at their site where they eventually deposit. Okay, so type 3, just like we talked with NC3 deficiency, is composed of 3 things. Most people think it's antigen-antibody. Well, it's antigen, antibody, and complement, because you need the complement cascade for the further destruction of those tissues. So 3 things in type 3, important to remember. Examples of type 3, right? So if you have one of the classic ones that likes to pop up on tests is serum sickness. This is essentially a antibody antigen complex that is formed when you get antivenom. So you have antivenom for any kind of snake bite or scorpion sting, and your body has these antibodies that are going to attack that antitoxin, form complexes, and then move to tissues and damage them further. Clinical features of this are going to follow 1 to 2 weeks after the initial exposure, because your body needs time to form those antibodies, right? So you'll get the antitoxin, and then this is going to be a little bit delayed. It takes several weeks for these things to form usually. So fevers, rash, arthralgias after receiving antitoxin is common in things like serum sickness. Okay, you can also get this from antibiotics. So penicillins, amoxicillins, TMP-SMX is a classic one, and that can also form antigen-antibody complexes, as well as a key thing, you'll see this in hepatitis B infections. Hep B infections causes these kind of aberrant proteins to form, and you have antigen-antibody complexes forming there. So remember that serum sickness is a type 3. Another classic one that likes to pop up is called the Arthus reaction. Now, the Arthus reaction is a type 3 hypersensitivity that's local, not generalized. And usually when we think type 3, we think generalized, we think lungs, kidneys. So in this local one, you'll have a kid that's vaccinated or an adult that's vaccinated with tetanus or diphtheria, and then you have those antigen-antibody complexes forming locally in the skin. You get complement activation and possibly necrosis. So if you have erythema, necrosis, hemorrhage after a Tdap vaccine, that is an Arthus reaction, and that's one of the things that sometimes they like to test about that. Okay, next we have type 4 hypersensitivity reactions, and these are the most delayed hypersensitivity. So if 1 is the quickest, 4 is the most delayed. You can think of it like that. And in this reaction, you have a cell-mediated T cell response to sensitized antigen. So you have skin, usually it's skin exposure, and this antigen rubs on your skin, like let's say poison ivy, and then it gets taken up by Langerhans cells, goes to the lymph nodes, and sensitizes the T cells. The T cells then, usually CD4 T cells, then respond after the second exposure, and they release inflammatory lymphokines, TNF-alpha, activating macrophages and other phagocytic cells. You also have CD8 T cell activation, which causes cytotoxicity and other cell destruction to start happening. But mainly it's going to be CD4 that's the key player here. So the main example for type 4 is allergic contact dermatitis, either from things like poison ivy, which is very common, latex, rubber gloves, nickel. All of these are type 4, and they're going to have skin manifestations just like type 1. You could have itching. You're going to usually in this kind of presentation, you'll have a vesicle formation. That's more common in type 4 than type 1. And it's also going to take some time for this, after the exposure, for this to happen. So if you have something that you were exposed and then you instantly got an allergy, that's type 1. If you were exposed and then let's say a day, 2 days, a week later, you started developing a rash without no obvious exposure, then you're more likely to think it's type 4. Okay, and in this case, just like with type 1, you want to avoid the allergen and treat with steroids until it goes away. Some of these rashes can take quite a while to go away, and they usually, also another key giveaway in the rash is that they appear in kind of a linear pattern following the lymphatics system. So linear pattern is not just for things like herpes zoster. It can also happen in things like contact dermatitis, where you have this reaction usually on the hands, legs, in the belt area, if we're talking about nickel exposure, or where you wear rings and jewelry. And that's another one. So that's type 4. Another example of type 4 would be something like a DRESS syndrome, where you have drug exposure, DRESS, Stevens-Johnson. Those are drug exposure type 4 hypersensitivities, which are not topical, they're kind of ingested drugs, and so the rash for these are going to be a little more widespread. They're not going to be so localized. Things like allopurinol can bring on these rashes. Things like lamotrigine, phenytoin, the anti-seizure drugs, and antibiotics, sulfonamides can do it too. So watch out for the DRESS syndrome. These are kind of systemic type 4 hypersensitivities. Okay, so quick review. Let's go through each one and just summarize the key points. Type 1 hypersensitivity reaction. It's IgE mediated, it's the quickest, it causes hives, anaphylaxis, and basically type 1, fast and furious. You're going to get the reaction instantly. Okay. Type 2 hypersensitivity reaction. This reaction is IgM-IgG mediated, unlike type 1, which is IgE, right? It causes cytotoxic reactions with NK cells and macrophages, which later then activate complement. And the pathophysiology essentially is that you have an antibody which results in a cytotoxic reaction formation. Okay, these are related to autoimmune disorders, good pastures, lupus, things like that. Okay, so watch out for type 2 autoimmune, we can say it like that. So type 3 is composed of 3 things: antigen, antibody, complement. These are complexes, okay? A, B, C, the third letter of the alphabet, complexes. They like to deposit in blood vessels, they like to deposit in tissues, so you're going to have the kidney and lung damage usually. Serum sickness is here. Remember, the serum sickness is for antivenom. You're going to have Arthus reaction. Remember, that's a Tdap vaccine where it's localized. All right, so that's type 3. Type 4. Type 4 is T cell mediated. Okay, T cell mediated. It's going to be either poison ivy or contact dermatitis, and DRESS syndrome, Stevens-Johnson's are also under this umbrella, and that's a more widespread infection. Widespread dermatitis with an ingested drug. Usually one of the anti-seizure drugs or allopurinol will give you that. All right, so we've gone through hypersensitivity reactions. What else could we talk about? We could talk about things like what's another high yield thing? Oh, let's talk about HIV. So HIV is very commonly tested, HIV and AIDS. So AIDS is essentially the late stage of HIV where your CD4 count goes below a certain threshold. And depending on how low your CD4 count gets is what kind of infections you'll get. So if you're considered having AIDS, your CD4 count is going to be less than 200. But even CD4 counts less than 500 can predispose you to certain conditions. So let's talk about CD4 count related infections because I see them tested all the time, and I think it's important for us to review them together. All right, so Kaposis sarcoma. This one, you don't even need to be in AIDS to get it. You have CD4 count of 500 or less, okay? This kind of dermatologic disease, you'll have vascular proliferation, things like near the mucosa. I've seen it in patients on the legs before as well. It's caused by the virus HHV8, human herpes virus 8, and it's treated with interferon or laser therapy. So Kaposis sarcoma, you'll have these purplish lesions on the body, on the skin, the mucous membranes, and it's associated with, it's an AIDS associated infection, HHV8 infection, usually treated on the skin with alpha interferon. Cervical cancer is another thing that's associated with AIDS, and you see that with higher CD4 counts as well. There's no specific limit for that, but remember HIV is an immunocompromised condition, and AIDS, right? And with those, you're going to have a predisposition to getting things like cancer. Another cancer that's commonly tested with HIV is lymphoma. Primary CNS lymphoma especially, with a CD4 count of less than 100, so you're definitely in AIDS territory by then. Hodgkin's lymphoma is seen too with low CD4 counts, and this virus here that's causing this is EBV. So usually in the PCR of the CSF, you're going to find EBV DNA. You can also have, with this kind of lymphoma, definitely focal neurologic deficits, ring-enhancing lesion on the MRI, or CT scan. So remember, ring-enhancing lesions is not just for toxo. You also can have ring-enhancing lesions for lymphomas, for HIV less than 100 CD4 count. 100 is important to remember here. Reactive tuberculosis. The CD4 count here is not so low, it's 400. So TB, if you have a low CD4 count, you're not well equipped. T cells are some of the main cells that deal with tuberculosis, especially if you have latent tuberculosis and then you have a reactivation. Remember, the PPD test for HIV or AIDS infected people is going to have a lower threshold than for most of us. So it's going to be 5 millimeters for them because their immune system is ramped down. So it's not going to be as prominent. So the threshold for PPD positive is less in HIV people, and reactive tuberculosis is very common, especially in the early stages, even with a CD4 count of 400 or less. Coccidiomycosis. So coccidiomycosis is, in these cases, is usually disseminated and extrapulmonary. So in immunocompetent people, coccidiomycosis tends to affect primarily the lungs, but in people with CD4 counts of 250 or less, you're going to have disseminated coccidio. You'll have all the presentations. You'll have the shin lesions. You'll have the cavitary lesions in the lungs. And here you're going to treat with amphotericin B or itraconazole. And these patients have CD4 counts of less than 250 or lower. Screen for coccidio in kind of the Napa Valley regions, the dustier regions of the country, and keep that on your differential for people with HIV, definitely. Cryptosporidiosis. So this one is an intestinal infection, usually seen with people with CD4 counts of less than 100, and these are acid-fast infections. So on the stool culture or stool analysis, you're going to see acid-fast organisms. These people are going to have chronic diarrhea of greater than a month, and the antibiotic to remember here is nitazoxanide. Nitazoxanide is I think it's the knit glove or knit stocking in the Sketchy sketch, if you guys watch those. So usually if you restore immune function, your cryptosporidiosis will go away, and this is a pretty low CD4 count of 100 to be dealing with this, so it's going to be late on in the AIDS progression. Next, we can talk about PML. PML is a great one because it's hard to remember, and so they love to test it. So progressive multifocal leukoencephalopathy. You'll have focal neurologic deficits. MRI is going to show non-enhancing lesions. So remember, in our lymphoma, it's going to be enhancing. In our PML, it's non-enhancing. And here you only have supportive measures. Really, the outlook for PML is very bad in HIV patients. So these are going to be white matter lesions that are non-enhancing. PCP pneumonia, so very commonly tested, extremely commonly tested. It's an AIDS-defining illness. If you have PCP pneumonia, you can bet that your CD4 count is going to be less than 200 in most people, right? So this is a diffuse ground glass opacity on the X-ray. On the labs, if you want to do a lab test, you can test for beta-D-glucan. It's going to be elevated in these people, and so you'll have a person that comes in with fever, dyspnea, a non-productive cough. That's important to know. It's non-productive, it's ground glass, it's AIDS defining, and you treat with TMP-SMX, steroids if required, and then essentially there's a steroid cutoff for the PaCO2 and PaO2, which isn't coming to mind right now, but remember to add steroids, there is a specific cutoff for lung function tests, and I'll look that up and we can talk about it in the next podcast. So moving on, there's a bunch of other infections we can cover. Another one, if we're staying in the kind of fungal route, is histoplasmosis. Histoplasma is, again, disseminated in AIDS. It's not going to be like just localized, and so it's going to be another one of those extrapulmonary disseminated infections. Usually CD4 counts less than 150. You're going to have someone with fatigue, fever, weight loss, dyspnea, diarrhea, abdominal pain. See, it kind of goes everywhere. You can get hepatosplenomegaly in these cases, and this yeast is going to be essentially a group of clusters that you'll see inside of macrophages. So out of all the yeast infections that are opportunistic with HIV and AIDS, this one is, I believe, the smallest because it fits inside the macrophage easily. So you'll have a little cluster on the histopathology slide, and you treat this with amphotericin B for 2 weeks and then itraconazole for 1 year. So it's an extensively long treatment for these people. And you can do prophylaxis if you see the CD4 count for someone is less than 150. Cerebral toxo, this is our other ring enhancing lesion. Usually you'll see multiple, and instead of one, like in the lymphoma case. And this is an infection that comes from cats or animal products. In these people, you'll have focal neurological deficits, seizures, fever. You can also have toxoplasma chorioretinitis, where it affects the eyes, and you'll see kind of a diffuse haziness at the back of the eye from the inflammation. These people receive pyrimethamine, sulfadiazine, and folinic acid or leucovorin as their treatment course, and you want to watch out for cerebral toxo in people with CD4 counts of less than 100. Next is Cryptococcus. So Cryptococcus is one of the main causes of meningitis. It's an interesting yeast that you'll see kind of on India ink stain that's highly tested. You'll have the main treatment here for Cryptococcus is amphotericin B, followed by either flucytosine or fluconazole. I think flucytosine is more commonly seen on tests for the treatment strategy, and this is one of the key ones that's treated with amphotericin B, so remember that. Because amphotericin B isn't that common of a medication used, and fungal infections in general, if you're on the wards, they're kind of pretty rare to see severe fungal infections, unless you're dealing with chronic AIDS patients. Then they become more common. So as soon as you see kind of an atypical infection, something that's a little bit more rare, you can suspect immunodeficiency, you can suspect HIV, and you should be testing for it. Candidiasis is also seen, and this is kind of a candidiasis that's either in the trachea, in the lungs, in the esophagus, in the bronchi. It's like a pulmonary candidiasis, so you can go anywhere from the mouth all the way to the lungs. You have esophageal candidiasis, which is kind of gnarly. If you see it, it's these white plaques that form on the inside of the esophagus. And usually it starts out with an oral thrush, and then you'll see the white plaques in the esophagus. You'll have dysphagia. These plaques will be scrapable, and on microscopy you'll see the pseudohyphae of Candida. Treat with nystatin. If it's disseminated, you'll have to move up to amphotericin B, but the nystatin switch and swallow is just if it's localized to the mouth. Herpes simplex. Herpes simplex can also cause an esophagitis, just like Candida. And Cytomegalovirus can also cause ulcers and esophagitis. So the 3 esophagitis causing bugs are Candida, herpes simplex, CMV. In herpes simplex, the esophagitis is going to be after at least a month. You'll have these kind of linear ulcerations in the esophagus, which differentiates it from the CMV, which is kind of a volcanic circular ulcerations. And in herpes simplex, you have acyclovir as the main cornerstone of treatment. You can switch it to valcyclovir, famciclovir as needed. If those don't work, you can move on down the line to foscarnet and cidofovir. Those drugs are kind of second line, but they're for resistant. So the key point there is resistant HSV, foscarnet, cidofovir. That's also highly tested. So they'll give you a patient, they got acyclovir, it's not working for them. That points to the resistance, and then you say, okay, well, now we have to switch to either foscarnet or cidofovir because they are more effective for resistant strains, especially in immunocompromised people. But remember, these things can cause nephrotoxicity, so watch out for kidney function there. Cytomegalovirus, that's one of the infections that your CD4 count has to be pretty drop dead low to kind of get it. CMV can cause things like colitis, cotton wool spots in the eyes. The owl, you'll see on the biopsy the kind of owl's eye appearance in the tissue on the that's a classic, essentially histoimmunological finding, the owl's eye, intranuclear inclusions. For cytomegalovirus, remember your CD4 count is going to be low. It's going to be usually below 50. So the treatment here is ganciclovir usually, and then for resistance you have foscarnet and cidofovir again. So remember, CMV, esophagitis, retinitis, those are the 2 main ones they want you to probably remember. And tuberculosis, the last one is tuberculosis-like disease. So this is encompasses things like MAC, Mycobacterium avium complex. These MAC infections are really low, associated with really low CD4 counts, less than 50. You're going to have kind of tuberculous-like symptoms, sputum production, weight loss, night sweats, and you treat with clarithromycin, azithromycin, so macrolides, ethambutol. So clarithromycin, azithro, and ethambutol as an add-on. And you definitely want to prophylax for MAC if the person has persistently low CD4 counts with azithro. Okay, so we went through kind of the opportunistic infections associated with HIV and their CD4 counts. So remember that you don't even need super low CD4 counts for things like reactive tuberculosis, coccidiomycosis. You're not even in AIDS territory for that. But you do need super low CD4 counts for things like cytomegalovirus infection, tuberculosis disease. You'll have cerebral toxo, histoplasma, crypto, and candida. Those are associated with pretty low CD4 counts of at least less than 100. All right, and some of these are definitely considered AIDS defining. So if you have them, there's no question about your CD4 count. You don't even need to measure. You're already in AIDS territory. Okay, so how do you treat HIV? That's going to be, I think, our next topic of discussion. So you can have NRTIs, NNRTIs, things like protease inhibitors. What else? Integrase inhibitors are definitely there. And so the mainstay of treatment is in HIV, and I would remember at least one of these drug regimens, because on step 3 there's a CCS portion where you have to essentially type out your orders for medications that you'd order, and there has been, I've seen a case where you get HIV as your diagnosis and you need to know the drug regimen to type in there so you can prescribe it for the patient. So the recommendations as they kind of stand now are either 3 NRTIs or 2 NRTIs and 1 adjunct, like an NNRTI, a protease inhibitor, an integrase inhibitor. So the NRTIs are kind of the most high yield ones to remember. So let's go through some of the NRTIs, the nucleoside reverse transcriptase inhibitors. Those are things like zidovudine, lamivudine, emtricitabine, abacavir, stavudine, didanosine, and tenofovir. So what they essentially do is they competitively block the nucleoside binding site of reverse transcriptase, and they stop the 3' to 5' phosphodiester linkage in HIV DNA replication. Okay, so they inhibit the reverse transcriptase RNA to DNA process of HIV replication, and that's how they kill the replication cycle of HIV. And each of them have their own nucleotide that they work with. I don't think it's so high yield to know which nucleotide is for which, but knowing their names is pretty important. So we've listed their names again. It's zidovudine, lamivudine, emtricitabine, abacavir, stavudine, didanosine, and tenofovir. So if you know at least 3 of those, it's a good head start on your HIV treatment regimen. Remember that these drugs also have side effects. Common ones they like to test are hepatic steatosis, myopathies, lactic acidosis. Remember, abacavir has its own associated hypersensitivity. If you have and you should avoid it in people with HLA-B5701 positive patients. So I wouldn't start with abacavir unless you have that sensitivity already handled. And pancreatitis is a common one for didanosine and stavudine as a side effect. Lipodystrophy is also a common side effect of these drugs. This is like a Cushing-like syndrome where you can have the altered fat redistribution, and you're going to see that person has low HDL, high LDL sort of deal. And to remember, tenofovir can also cause nephrotoxicity. So out of those drugs, tenofovir is the nephrotoxic one. NNRTIs, these are going to be non-nucleoside reverse transcriptase inhibitors. The ones that are well known are nevirapine, efavirenz, and delavirdine. Delavirdine's not as, I think the exam writers, they've watched Sketchy, so if it's not a common drug mentioned in Sketchy, that's the one they'll kind of lean towards because they know most people won't know it. It's kind of how they do some of their filtering. So delavirdine is one I would watch out for. I don't think it's as prominent in the Sketchy pictures as efavirenz and nevirapine. So these work by binding reverse transcriptase and essentially stopping its activation not from the nucleoside binding site but from an adjacent one. And they also don't come without side effects. Nevirapine is hepatotoxic. Efavirenz is CNS has CNS toxicity with associated vivid dreams, and they can cause also Stevens-Johnson syndrome and rashes. So that's kind of how they work. Some of their side effects. Next we can talk about integrase inhibitors, or let's talk about protease inhibitors first. This is the navir ending drugs, indinavir, ritonavir, nelfinavir, things like that. Their mechanism of action works by inhibiting the HIV protease, which stops the cleavage of mRNA into functional units. So you aren't able to kind of separate your mRNA chunks, and that leaves it into one big clumped up mass, which then gets degraded. So here the common side effects that they'll test you on the protease inhibitors are lipodystrophy, just like with NRTIs, and thrombocytopenia is a common one for indinavir. Hyperglycemia is another one that they like to go for, and nephrolithiasis plus hematuria. And the hematuria can be either from the nephrolithiasis or the crystal-induced nephropathy. So watch out for kidney dysfunction, lipodystrophy, and platelet dysfunction in these drugs. All right, and the integrase inhibitors, those are things like, they're not as high yield, but I would remember some of them. Raltegravir is a good one to remember. Essentially, they end in gravir, so dolutegravir, raltegravir, abitagravir. Those are the ones that basically work by stopping HIV integrase, which stops viral DNA from entering into host DNA and inhibiting the replication that way. The side effects for these ones are increased creatinine kinase. So they'll show you maybe like they'll try to trick you with a rhabdomyolysis type picture, and then they'll tell you the person's on an integrase inhibitor. And that's pretty much it for the HIV drugs. One other one that comes to mind really quickly is the entry inhibitors. These I don't see tested as often, but I think we should just quickly touch on them. They're enfuvirtide, which is a fusion inhibitor, maraviroc, which is CCR5 antagonist, and they work, I'm not 100% sure, I don't remember exactly how they work, but they're good ones to remember because they can just pop up on an exam randomly. All right, so 3 NRTIs. The ones I like to remember are zidovudine, lamivudine, and abacavir. Or you can do 2 NRTIs plus one other random one. So you can do lamivudine plus abacavir, and then add on efavirenz, or add on leponavir, or add on raltegravir as your indinavir instead if you don't like leponavir as your protease inhibitor. And these ones are kind of the go-to regimens. So another thing that you should be aware of is that hepatotoxic drugs, for example, nevirapine, they're contraindicated if you have a co-infection with hepatitis B or C. So watch out for nevirapine. They'll try to get you to give it when the person has a co-infected a positive HPV or HCV test, and that's a very kind of common test question there. All right, so we've talked about basically HIV antiretrovirals. What else could we talk about? We could talk about another common big infection that they like to test is tuberculosis. So let's talk about tuberculosis drugs. So that's RIPE therapy, right? And the mnemonic here that I like to remember is 4 for 2, 4 for 2, and then 2 for 4, right? So if you add 4 plus 2, you'll get 6 months. So you'll have 4 drugs for the first 2 months, and then you'll have 2 drugs for the next 4 months. So together you'll have 2 drugs that run for 6 months, and then you'll have 4 drugs that run for 2 months. If that makes any sense, okay? So essentially what I mean is that you'll have 4 drugs, RIPE, rifampin, isoniazid, pyrazinamide, sorry, and then E is ethambutol, right? And then rifampin and isoniazid, the first 2 letters of RIPE, are going to go for 6 months, and then pyridoxine and ethambutol are going to go for 2 months. So for the first 4 for 2, right? For the first 4 months, or for the first 2 months, sorry, you're going to have all 4 running. And then 2 for 4, you're only going to have RI running for the next 4 months. Okay, so RIPE, RI runs for 6 months, PE runs for 2 months. They all run together for the first 4 months. 4 for 2 and 2 for 4. I hope that makes sense. And it's just how I remember it. And so let's go through some key qualities of these drugs. Okay, so rifampin, one of the things you have to remember is that it can be hepatotoxic. It causes the orange discoloration of bodily fluid like urine and tears. It's a P450 inhibitor, so if you have, like, for example, patients with HIV or who are on heart therapy for antiretrovirals, right? You don't want rifampin because it'll mess up your metabolism of HIV drugs. It'll also mess up your metabolism of OCPs, so people can get pregnant if they don't get metabolized properly. And you can have false urine opiate screenings with rifampin because it can pop up as positive. So important thing to remember about rifampin there. Opiates, HIV don't give it. Orange fluids, hepatotoxic. Isoniazid, this one they love because you have to give B6 to stop neurotoxicity. Just remember, you need to give pyridoxine, and don't mix that up with pyrazinamide. Pyridoxine, pyrazinamide, they kind of sound the same. So pyridoxine to stop peripheral neuropathy. It can, in high doses, it can precipitate benzodiazepine seizures. It can cause anion gap acidosis. It can cause pellagra. Pellagra, remember, is a B3, not a B6 problem. So B3 and B6 can both be kind of affected by isoniazid. It's hepatotoxic again, so that's our second hepatotoxic drug. Remember to get LFTs on people with tuberculosis because these drugs are hepatotoxic. It can cause drug-induced lupus. That's it's one of our drug-induced lupus drugs, along with like something like a procainamide. So just remember all the drug-induced lupus associations because they like to pop up on tests. And it can also cause optic neuritis. So isoniazid, again, just like rifampin, they can both be hepatotoxic, but this one's more CNS and neuro involved. It can have CNS toxicity. It can have peripheral neuropathy, optic neuritis. So focus on kind of the CNS symptoms and the hepatotoxicity there. Pyrazinamide, again, hepatotoxic. So all of our TB drugs pretty much, except for ethambutol, are hepatotoxic. LFTs are very important here. It can cause hyperuricemia, so uric acid, kidney stones, right? Watch out for those with pyrazinamide. Those are the two main ones to remember. And then ethambutol, you can have the optic neuritis with reversible red-green color blindness once you've stopped the drug. Remember that the rifampin or ethambutol color blindness, you want to do some eye tests before you give the drug, and then have some eye tests during that period to make sure they're not suffering from any kind of optic neuritis as a result. So remember that ethambutol as well as isoniazid have optic neuritis as a side effect, and RIP, rifampin, isoniazid, and pyrazinamide all are hepatotoxic, so you're going to need to get LFTs for these people. Okay, and another thing to remember is that rifampin and isoniazid are P450, cytochrome P450 inhibitors. So if you're taking RIPE therapy, or especially the first 4 months, right, or the whole 6 months, right, because you've run rifampin and isoniazid for the whole 6 months of therapy. So during that 6 months of therapy, you have to watch out for HIV drugs. If you're giving them, they might not be as effective. OCPs won't be as effective. Warfarin is a very key one to watch out for because you could potentially anticoagulate someone, go over on your anticoagulation. And sulfonylureas, if you're treating maybe potentially like a diabetes patient, you can cause them to go hypoglycemic. So some of the less common associations that they might try to trick you on are the warfarin association, the sulfonylurea association, and the OCPs. I've seen it tested a couple times. Watch out, as well as HIV. HIV is very important here. All right, so I think we've gone through a good chunk of content today. Hopefully this was helpful to some of you guys, and I'll see you in the next one.